W, you can make it visible for all. I think the video what you are showing only I am watching. Good evening all, welcome. So, I think you're all able to watch my PPT on the screen. I'm also watching it on another device. Hope I am clear for all of you. Yes. So I'm waiting for some of the people joining there online. So wait for a few seconds. So share the link with the people for live. So Bablu, share this link of YouTube. So good evening all, welcome all. So good evening Vijay, CSK, all people. I think it's time now. We will start the session because it's around 1 hour to 1.5 hours session. I don't know how long it will go. Okay, welcome friends. I'm fine. So most important thing I want to tell you here, this exam is purely, totally out of FMG pattern. This is not an FMG exam at all. This question paper which I was going through for the past 2 days, I'm covering the questions and I'm writing the things. So it's totally not a regular FMG paper. You all know very well. This is clearly at the level of INI set level. So definitely the students who have read extraordinarily can easily crack this. Otherwise, if you have gone very superficially, it will be very difficult to clear this exam. So you will see the questions and answers. We have around some around 48 questions I have collected from surgery. So 48 questions we are going to discuss now. So please share with your friends. So those who are all not live, they can also join live because this will help you to understand how to approach for the future exams also. So especially NEET PG aspirants also, I told most of them to join this session because this is going to be the pattern for future exams. Okay. So thank you, doctor. That's true. That's what I have posted in Instagram is true. That's really a tough paper for FMG level exams because this is an MBBS graduate qualifying exam. I don't know why for a qualifying exam they made such a tough paper for surgery. Of the 48 questions in surgery, all the questions, one point I can be sure is most of these questions are from standard areas, no doubt in that. But standard areas, you can ask the basic clinical knowledge or clinical aspects or basic investigations. This time, what they have done is they have made one small difference. What is this? The first thing what they did was they gave a question. They gave a question. Usually, what they expect in FMG exam, they will give a clinical question and they will expect the students to answer what is that disease. That's what usually the FMG examiners will expect. But this time, they gave the question, clinical question. They expect the students to know the answer. And from the answer, the student should know how to manage. Usually that type of questions are usually asked for INI set and for NEET SS. Even NEET PG, they won't ask that type of questions. You will be understanding. We are starting with the general aspects and trauma chapter. We had 11 questions from this chapter. Okay. Which of the following is true about the image given in the diabetic patient suffering from fever? So each question, let me tell you, I will write you one important thing, that is Fournier's gangrene. So all these questions are definitely high yield topics only, but you see the Fournier's gangrene, definitely all of you would have read. So Fournier's gangrene is a very classical FMG question. So this is a question on Fournier's gangrene. All of you know that well. So in a Fournier's gangrene, see, they have made a perfectly complicated choice. complicated choice to make you get more confused and make you wrong. That is the aim. The aim is to make you wrong. See, which of the following is true about the image seen in the diabetic patient suffering from fever? So you can see this is scrotal wall gangrene. All of you know scrotal wall gangrene is known as Fournier's gangrene. Abdominal wall gangrene is known as Melini gangrene. So Melini is abdominal wall. Fournier's is scrotal wall. So this all of you know very well. This is very well known to all of you. So this question you see, it is caused by Staphylococcus aureus only is wrong. So it is absolutely wrong answer. You know that very well. It is not caused by Staphylococcus. In fact, it is caused by polymicrobial. Among the polymicrobial, the most common organism seen is Streptococci. The most common organism seen is Streptococci. It is a Streptococci which is most commonly seen, but it is polymicrobial. Caused by Staph aureus is absolutely wrong. So the one thing you can be happy here is those who have read Fournier's gangrene will be very clear with one choice. Testis remains unaffected is known to 99% of all the students. So this question, I think by means of correct answer, you can write this correctly. So testis not affected is correct. That is correct. Symptomatic management is wrong. We have to immediately take this patient for debridement. Okay, debridement of the gangrenous tissue should be done. We have to debride the scrotal wall and we have to make the gangrenous area completely removed. Otherwise, it will keep extending underneath. So it is known as necrotizing fasciitis. The other name of this disease is necrotizing fasciitis. So it will go under the fascia and it will spread for long distances. So we have to do debridement. Scrotal support is not the treatment for this. Scrotal support is a treatment for architis. You all know that very well. Epididymo architis only we will do scrotal support. So the answer here is B. Okay, very good, Vijay. That's correct. Test is unaffected. So as FMG students, though the question will be causing more controversy and complications, you can answer this question clear cut because you know the answer already. Testis is not affected in Fournier's gangrene. Okay, that is not affected in Fournier's gangrene. Please don't forget this point. So very important point. Please don't forget this. First question. Okay. Second question. So the answer is from Bailey and Lau 28th edition. This paragraph, exact paragraph, is from page number 58 of 28th edition. I have made the questions purely from 28th edition. I have made all the reference also for you. So second question. So all of you know the second question is a classical question. This we have discussed in all the classes. Though this is not there in Bailey and Lau. This is not there in Bailey and Lau. This is very commonly used instrument in surgery for doing what type of anastomosis? If this is one bowel and this is one bowel, we insert this device and we make a side-to-side stapling. Please don't forget this. Side-to-side stapler anastomosis is done with the help of this. So this is known as, what is the name of this? This is known as linear stapler. Actually, it is local term is linear stapler. The real term is TLC. What is TLC? Transverse linear cutter device. So this is actually known as transverse linear cutter device. Transverse linear cutter device is known as TLC. Transverse linear cutter device. So please don't forget, this is transverse linear cutter device shown here. This is linear stapler. So definitely in future, you can get circular stapler device image also. So skin stapler also, curved stapler also will be shown and will be discussed in future classes. So it's essential question. Hereafter, this question can be asked in exam in any method. So the answer is linear stapler. I hope 99% of you would have answered it correctly. It is side-to-side stapler anastomosis known as transverse linear cutting stapler. Okay. So this is not there in Bailey and Lau. It is not updated in Bailey and Lau. It is from, they have asked linear stapler. No, linear stapler was asked in the exam. Any other device was asked there, Shubham? Maybe the device which was asked is linear stapler only. It's the device which was asked in the exam is linear stapler only. So question 25 years old male. See, this is a question which I was telling you, they have made more controversial and complicated questions. 25 years old male had met with bike accident and brought to emergency department. His BP is compensated. Okay, pulse rate is, BP is uncompensated and pulse rate is more than 140. So they are all known as uncompensatory shock. So in compensatory shock, BP pulse rate will be mostly normal. In compensatory shock, uncompensatory shocks, there will be alteration of the values. There will be alteration of the values. One of the most important values is mild, moderate, severe. And those who have not read this question before, this is a question directly from page number 15 of 28th edition Bailey. This is compensated shock, uncompensated shock. The classification table shows compensated shock, uncompensated shock. See, compensated shock, urine output is normal. So pulse rate might be mild increase, respiratory rate might be mild increase, but what is all normal here? Please don't forget, in compensatory shock, urine output, compensatory shock is also known as mild category of shock according to this feature. BP is normal. So this is a question classically from Bailey and Love. Uncompensated shock, when will the urine output starts reducing? From moderate. So the answer for this question is moderate. So BP starts falling from moderate. So moderate cases, BP and urine output starts decreasing. Anuria happens in severe case. Severe hypotension happens here. So the answer for this question will be better answer is moderate. So definitely this question is a classical question from Paley and Love, 28th edition, page number 15. Okay, please don't have any controversy in this. There is no controversy. Whichever questions asked in the exam are all clear cut. There is no controversy. That is confirmed because all the 48 questions are there in Bailey and Love. All the 48 questions are high yield concepts, no doubt in that. So we are very much upset because the questions what they have made is correct. Whatever questions they have asked, the concept of the question is correct. The questions are also very good. All the questions are also very good. But choices, what should be the choice? In every question, we should come to a diagnosis. This is the FMG question. So from the clinical questions, what should I do? From the clinical questions, you should come to your diagnosis. This is what we expect in FMG exam. But here, they are not even giving the diagnosis and they are giving some choices of management and they want you to, that means what? You should indirectly know the diagnosis, then only you can go to the choice. Like that they have made, you will understand when I'm going, no, you will understand like that every question. See this question. This is a very commonly asked another concept on Q-SOFA score. This is a question on Q-SOFA score. So I'm sure all the FMG students would have read Q-SOFA score because this is being asked many times in the exam. I have always told Q-SOFA quick sequential organ failure assessment score for shock is based on Royal Challengers Bangalore. So RCB is the answer for this. Respiratory rate, confused status, and hypotension. BP, systolic BP less than 100 millimeters mercury, respiratory rate more than 22 per minute. This is RCB. See, in a trauma patient, there is a sudden increase of respiratory rate and his BP is 90, his GCS is 10. Q-SOFA score for this patient includes all except. See, they have not even mentioned anything, but they have mentioned a question on includes all except. So this is a simple question. They would have asked, what is Q-SOFA? Does not include RCB except LDH. So the answer is LDH. So clear-cut answer, lactate dehydrogenase is not a part of Q-SOFA score. Very good, Vijay, very good Prince. I expect all of you to answer the questions. Only when you answer the questions, you'll know what mistake you have done. So far I am discussing each question. When I am discussing, I will tell you what concept. So hereafter you should read concept-oriented way. So the concept, what is asked in each question, please be thorough with those concepts. Don't worry about the questions or choices. So whichever concept being asked in the exam, that will be repeated in future. They will not ask the ditto questions. All of you, those who have read so many MCQ booklets would have known and realized now, no questions are getting repeated. Only the concept of the area will get repeated. No examiner in national board is going and sitting there with some question bank of any online platform or any MCQ books. They will prepare questions from the books only, from the standard Bailey and Law only. They will prepare questions. So therefore, it's time now, FMG students, you should have to modify yourself how to prepare for the future exams. Okay. So 36 years old female patient had recently undergone laparotomy. See, understand, she has undergone laparotomy. So that after laparotomy, what will be the sure sign of wound dehiscence? This is again a discussed question known as burst abdomen. Burst abdomen. What is the sure shot sign of burst abdomen? The question is asking for a burst abdomen. If it is going to happen, what will be the sure shot sign the patient will have? Yes, anybody? So sure shot sign of burst abdomen. This is concept of burst abdomen. So burst abdomen related concepts you should understand. The answer is copious serous sanguineous discharge. So very good, Vijay. That is a case of Salmon sign. This sign is known as Salmon sign. We have discussed multiple times in the classes. So Salmon sign. What is Salmon sign? Sudden gush of fluid in the burst abdomen. See, please remember, this is an abdomen closed laparotomy wound. So we have closed the abdominal wall with the prolene, and we have closed the skin with the skin sutures. Now the patient is in the ward. On which day this complication can happen? Burst abdomen can happen on 6th post-op day. When I'm doing the dressing, I am seeing sudden gush of fluid coming out of the wound, sudden gush of fluid. So gush of fluid coming out of the wound is because of the abdomen sutures, the prolene suture that has given up. And once you do dressing, you will see the bowel will protrude out. Bowel will protrude out. What should I do immediately? Immediately, I should close the wound with offsite dressing or vacuum-assisted closure device. Something will be needed to close the abdomen. Okay. So olden days, we used to do tension sutures. Now, tension sutures are not done by people. So tension sutures are no more advised. Better to go for offsite dressing or vacuum-assisted closure devices for patients who are having sudden burst of abdomen, Salmon sign. Very good, Prince Davis. It is exactly, that's the point here for NEET PG aspirants is burst abdomen is seen on 6th post-op day. Burst abdomen is seen on 6th post-op day is very important for NEET PG exams. Okay, don't forget this. That's the most important point for your exam. I want you to remember. Okay. An army person after blast injury. An army person after blast injury in a war is wounded. Yes, Bagota bag is also correct, Ajay Kumar and Prince Davis, that's correct. Bagota bag is nothing but a plastic sheet, that's all. That can be done in our Indian setup. We used to do that only. An army person after blast injury in a war, he is wounded with crepitations. He came to hospital on 2nd post-op day. See, on 2nd post-op day, he came to hospital. The patient has brick-shaped bacteria with spores. So actually, I don't know whether this is a surgery question or a microbiology question, but the question answer is very clear-cut, straightforward question because it's a war. In the war, the patient has gone to a war. In the war, there is crepitations. Crepitations is a feature of gas gangrene. Don't forget this word. Gas gangrene is a direct microbiology one-liner question for Clostridium perfringens. So this is a 28th edition Bailey and Lowe, page number 57 says gram-positive spore-forming bacilli naturally found in soil and feces. Immunocompromised patients have greater risk. Crepitus is the catch point. So why there is a major problem? Because they release collagenases, hyaluronidases, and alpha toxins. And most important, please don't forget, they have a brown, sweet-smelling exudate. Bailey and Lowe says this line of brown, sweet-smelling exudate. So please don't forget, brown, sweet-smelling exudate is a feature of this type of gas gangrene. Okay, so this is very important. So we have around 45 to 48 questions to discuss. So any question, if you want a detailed explanation, you can always post. I'm following your chat in the YouTube. So if you're having no doubts, we'll keep on continuing. But any controversial points, if you feel the choices are not exactly correct, you can always tell me that. That's why I'm telling you, Ajay Kumar. I don't know whether this is a surgery question or a microbiology question, because in microbiology, they might have given more features of this lesion. So whatever it is, the answer is very clear because of the crepitations. It's only Clostridium perfringens. Some people also told us anthrax. Anthrax and all will not happen with the air-forming bacteria. So it's air-forming, it is this. So this is again a only question, happiest question for the FMG students. Most of the time, they would have felt very happy seeing the non-contrast CT of this showing you EDH, which is showing you biconvex hematoma. Biconvex hematoma. Biconvex hematoma is shown here. Okay, this is a biconvex hematoma shown here. So, and another hematoma, you all know very well, this is concavo-convex hematoma seen in concavo-convex hematoma seen in SDH. Okay, biconvex hematoma. Okay, then no problem, but thank you. And then if the anthrax is a different question, nothing to worry. So this is biconvex hematoma. Treatment is burr roll because the bleeding is from which artery? Middle meningeal artery. In an SA subdural hemorrhage, the bleeding is from bridging veins. So bridging veins are bleeding. So we have to immediately do craniotomy. Craniotomy has to be done immediately for a SDH. SDH has 40% mortality. EDH has only 5% mortality. So question number 7 is a straightforward, repeat old question. Okay, so let us go on to the next question on 8th question. So actually, this was again I'm telling you, this is what I'm telling. In FMG exam, usually they give this clinical scenario. A patient presented with severe abdominal pain with nausea and shortness of breath. Usually the questions will be the patient had a chest pain radiating to the interscapular region. Radiating to the interscapular region will be the choice. So patient had a chest pain radiating to the interscapular region, and patient on measurement of the BP, the two limbs have different BP. Upper limb is having different BP. The answer is clear. Classical answer of that question is aortic dissection aneurysm. This is a well-known, very old question, aortic dissection aneurysm. And those who have read about this concept of aortic dissection will identify this is about aortic dissection. Seeing this picture, what is this picture showing you here? What is this anatomy? What is this? What is this image? This image is classical image of, what is this image showing you like this? What is this image? It is known as what sign? What is this sign? This is tennis ball sign. Please don't forget, this is tennis ball sign of aortic dissection. So aortic dissection is having a tennis ball sign. Very good, Dr. Sanjeev. That's correct. That's a tennis ball sign. See, the question has been asked. With image was there with a tennis ball sign. But the point is, you should have been having a clear-cut idea about aortic dissection. Those who have read this concept will directly know there is urgent surgery needed, no doubt. But urgent surgery needed is correct answer, but it is given in two places. Don't forget, urgent surgery is needed for aortic dissection. The point here confusing is what should be done now before controlling urgent surgery. What should be the next step means this is the latest norms. Please follow this latest norms from ATLS manual. Yes, that's correct. In initial management now is using control systolic pressure using esmolol has been added up in the ATLS manual. We have to keep the BP less than 120. We have to reduce the BP. Then only we can plan for either surgical direct repair or Dacron grafting. Nowadays, there is more and more of endovascular stenting known as EVAR. Endovascular aneurysm repair has been upcoming procedure. Endovascular aneurysm repair is an upcoming procedure. But don't worry, but in this FMGE exam, the question was asked about urgent surgery. That's all. So there are two questions in this, which I will tell you should go for A. Answer should be urgent control of BP followed by urgent surgery. Okay. What is the investigation of choice? This is a NEET PG question for aortic dissection. Yes, can anybody tell me, NEET PG aspirants who are attending the class, please answer this question. Investigation of choice for aortic dissection. Yes, here the CT is there, but this is not the correct answer. CT is the answer for stable patients. In unstable patients, what is the answer? Unstable patients, TEE, transesophageal echo. Yes, CT angio is the stable patients. We do CT angio, that will show you tennis ball sign. In unstable patients, we should do bedside transesophageal echo. Okay, don't forget this point. So whatever it is, once aortic dissection has been diagnosed, go for esmolol followed by surgery. Okay, that's the 8th question. So coming to the 9th question. Very good, very good. I'm seeing for anybody answering the transesophageal echo, Dr. Tejakumar has answered it correctly. Ashish, correct. Viji, correct. So excellent. So transesophageal echogram is the investigation of choice for unstable patients of aortic dissection, aneurysms. Okay. Which of the following feature is most commonly seen in all types of shock? All types of shock. There are many shocks, you know very well. So in all the shocks, what will be seen? Increased peripheral resistance, increase in respiratory rate, hyperthermia may vary with different type of shocks. But what is shock? Definition of shock is decrease in tissue perfusion. That is the common answer for all. Shock means decreased tissue perfusion. This is the shock is defined as a systemic state of low tissue perfusion that is inadequate for normal survival of the cells. So now you can see when I'm going and seeing each shock will vary. See, for example, cardiac output, it is high in septic shock. Systemic vascular resistance, low in septic shock. Venous pressure is low in hypolimic shock and septic shock, but it is high in cardiogenic and obstructive shock. MVOS is high in septic shock. Base deficit is more or less common in all. So you can get in future this question. So which of the following is equal in is found the same in all shock? This is from this table in Bailey. Now this is actually these are all INI set questions. I'll tell you these are INI set questions. Actually, these are NEET SS questions. NEET SS PG level questions. Even PG students might get confused seeing the choice. So, but the question is complicated, but the choice is very simple. Basic definition. Definition of shock is decrease in tissue perfusion. So in all types of shock, you may not get urine output in the initial stages, no? So that cannot be taken into account. So yes, decrease in tissue perfusion is the best answer in this. Decrease in tissue perfusion includes decrease of renal blood flow, okay, decrease of renal blood flow, decrease of oxygen to all the essential core tissues. All those things will come under this. So the answer is simple. 9th question. So image of the baby with a hemangioma on the eye and face. Baby is having a hemangioma on the right eye and face. There is a question like this. So it's a very simple classical question. This is known as what? Hemangioma. What do you call this hemangioma as? This is strawberry angioma from Bailey&Lowe. This is from Bailey&Lowe. Strawberry angioma known as capillary hemangioma. What is the other name for this? This is actually known as birthmark. It's also known as birthmark. It is seen at birth. Please don't forget, it is seen at birth and maximum disappear by how many years? So please don't forget, strawberry angioma is seen at birth and will be disappearing by maximum 7 years. Maximum 7 years, they will disappear. See the line from Bailey&Lowe. Capillary hemangioma or strawberry nevus. Commonest birthmark. 90% are seen at birth and 70% resolved by 7 years. White skin affected commonly, most common in girls. It is a consequence of vascular thrombosis, fibrosis, and mast cell infiltration. This is a classical question of capillary hemangioma, very common birthmark for the small babies. Okay, so no confusion in that. It's a straightforward, non-controversial question. So these are all questions which you can answer with the in-depth preparation of the trauma. So this one question is enough to judge whether you have prepared trauma in depth or not. Okay, that's the question on 4 patients came to hospital with the 4 different symptoms. Match the correct match, you should point it out. Extradural hemorrhage will cause what type of pupil? It is not pinpoint pupil. Pinpoint pupil is in pontine hemorrhage. EDH will have fixed, dilated pupil known as Hutchinson pupil. So the first one is wrong. Penetrating injury of eustachian tube. Eustachian tube penetration may not cause CSF photoria. CSF photoria is a feature of middle cranial fossa fracture. Middle cranial fossa fracture only will cause EDH. Will has CSF photoria. Penetrating injury to the eyes will not cause battle sign. What is battle sign? It is also a middle cranial fossa fracture. The problem is there is pigmentation behind the mastoid process. Behind mastoid process, there is pigmentation. So the first 3 are absolutely wrong. If you have a doubt about gaze paresis, that is the correct answer. Gaze paresis is seen in midbrain. So if you are wondering where this question is from, never ever think of anything. It is only from Bailey&Lowe. Direct line from Bailey&Lowe. Midbrain or brainstem dysfunction leads to, see, it leads to gaze paresis, inability of the eyes to look across. What is gaze paresis? I am not able to view on this, above this midline. So only up to off point, I can visible. I cannot see across the midline. I am unable to see. That is known as gaze paresis. There is another condition known as disconjugate cases in which inability of the eyes to work together and rolling eye movements, all these are seen in midbrain or brainstem dysfunction. So midbrain or brainstem dysfunction will have gaze paresis. So this is a new question. So definitely this is a new question, but if you can answer this question by exclusion method, you can answer this question. CSF photoria, battle sign, all are seen in base of skull fracture. So this is about the general and trauma chapter related. 11 questions came from the general and trauma questions. And among the 11 questions, only 6 questions are standard FMGE questions. Around 5 questions are totally confusing and more in-depth knowledge questions. So 6 questions, but you can easily answer 6 questions in this general topic. Okay. So now let us go on to the basic clinical chapters of head and neck, breast, hernia, thyroid. So the first question, which of the following involvement is given in this image? So this answer is very well known answer for all of you. I am 100% sure you all would have answered it correctly. This is Pew D orange. Pew D orange is an orange skin-like appearance. Orange skin-like appearance in cancer breast, which comes under T4B. It is due to superficial lymphatic infiltration. Superficial lymphatic infiltration causes this PUD orange. It comes under T4B. So that is, I don't think there is no further discussion needed for this question. So it is T4B, PUD orange. So this question is highly expected for this year NEET PG again, because this question has been asked in NEET FMGE exam. So I'm asking all the NEET PG aspirants to please share this video with your friends. Definitely in this 48 questions, you can get more questions in surgery, because the same examiner is going to set you the same paper, okay? So not hematogenous spread. Hematogenous spread will form satellite nodules. So arterial spread, if it is going to the breast, it will form only satellite nodules, not this condition, okay? It is only superficial lymphatic. Satellite nodules will be seen on hematogenous spread. Your question is correct, but the point is it will not form subdermal this appearance, PUD orange, okay? So this is a genetic testing for BRCA1 and BRCA2. When will you do? That's the question on when will you do BRCA1, BRCA2 testing. But for understanding this, you should know BRCA1 and BRCA2. BRCA1 is most common, in which the patients can get cancer, and breast cancer is seen and ovarian cancer is seen in the families. So they develop the cancer in very young age. BRCA2, the patients will develop breast cancer, ovarian cancer, male breast cancer, colon cancer, prostate cancer. So many cancers are there. Gastric cancer, pancreatic cancer, many other cancers may be associated with BRCA2. So in both BRCA1 and BRCA2, the cancers are seen very, very early, not late. They are all seen before some 25 years only, they will all develop cancer. That is why for both these girls, we have to do prophylactic bilateral simple mastectomy plus bilateral salpingo-oophorectomy should be done for all patients with this mutation. Now you can see the question choices. So male with breast cancer, definitely male breast cancer, BRCA2. Bilateral breast cancer, yes, when there is a bilateral breast cancer, there are chances of lobular breast cancer can be seen, and bilateral breast cancer is usually a lobular type of breast cancer. So it can be associated with familial mutation. So bilateral breast cancer, okay, bilateral can be taken into account. And another last one is breast and ovarian cancer. I told you they all are common in BRCA1 and BRCA2. So woman with breast cancer after 50 years, it's normal. It's a sporadic cancer. So the answer here is B. So it's actually a simple question if you don't think too much. If you think too much, you'll make wrong. That's all. So logical question from BRCA1, BRCA2 mutation. So many questions came from this. I'm happy that so many questions, but all the questions are mostly from staging. 50 years old presented to hospital with the complaints of mass in the right breast. See, this is a very essential question. Yes, Gas Paris is totally new question. Aziz Mohammed, that is totally new question. That is not possible for anybody to answer. Maybe you can answer it by exclusion from other three, but definitely most of the students would have gone wrong in that. 50 years, but it is there in Bailey and Love. That's why I'm telling you, it is there in Bailey and Love, but it is not being asked before, so it is a new question. 50 years old woman presented to hospital with complaints of mass in the right breast. So NEET PG aspirants expected MCQ this is. On examination, there is a mass movable and further investigation noted. Left axillary node. So axillary node is N1. That is why, see, all are N1. And she had no systemic involvement. That is why it is all M0. So all that is excluded. So only we have to know she had neoadjuvant chemotherapy given before. What will be the tumor staging now? See, you should understand what is this C, what is this Y. Again, this is a new question for NEET PG students. This is already a very old question for INI set and for NEET SS exams. C stands for clinical TNM staging. Y stands for post-neoadjuvant. Please don't forget post-neoadjuvant TNM staging. So any staging done after chemotherapy. After giving chemotherapy, if you do a staging, it comes under post-neoadjuvant. So the point is, it is between these two only, YT3 or YT4, you have to know. And it is undoubtedly T4 because there is skin ulceration seen. Ulceration of the skin is coming under T4B. So the answer is D. The answer for this question is YT4N1M0. So this is a case of clear-cut case of T4N1M0. Please don't forget this point. It's a case of T4N1M0. Y type. It is not. Yes, that's correct. It's because this question unwantedly they won't bring Y into the choices because they want you to know what is the meaning of Y. Because even the first MBBS student will tell it is a skin involvement, so it is T4. They want you to understand there is one content known as Y. If you know what is Y, then you can answer this question correctly. So Y means post-neoadjuvant chemotherapy. If this neoadjuvant chemotherapy was not given, means we will go for CT4. But there was a line mentioning chemotherapy was given for these patients. Please don't forget. The answer is YT4N1M0. So see, simple question. So sometimes some simple questions also will come. No, so like that one, there is a simple question. Contralateral nodal involvement is definitely a METS. So it's very important. What are all considered as METS in cancer breast are? Please don't forget, contralateral nodal involvement is METS. But please remember, if there is cancer in other breast, if there is a cancer in other breast, you do separate staging for that cancer. Bilateral cancers do separate staging. We won't consider it as METS. Okay, don't get confused in this. 2, bone METS. 4, liver METS. 4, lung METS. These are all commonly seen. Most common METS is to lymph node. Don't forget that. And most common distant METS is to bone, lumbar vertebra. Okay. X is, there is no such term known as X means not accessible. X means not accessible. It won't be there. We cannot find out what staging it is. X means not accessible staging, not accessible. So this question is a simple question. Reducible mass in the left side of the inguinal region. Cough impulse seen. It is an expansile impulse. After further investigation, it was known as inguinal hernia. So the question is, they would have asked, what is the treatment of choice for hernia? Answer is hernioplasty. So hernioplasty is a treatment for adults. If the same picture was given as a small baby, please remember, NEET PG aspirants, if a small boy was put like this, having a small swelling, you should go for children less than 14 years to 18 years. Also, sometimes it is acceptable. Herniatomy. Definitely, if there is a pediatric question, you will go for only cutting and removing the sac. We don't do mesh. Okay, don't forget this point. So this question, I'm searching the answer. I'm not sure whether this question is taken from any book. Which of the following shape of pelvis have a recurrent hernia? Which of the type of pelvis will have a recurrent hernia? Usually it will be short and wide pelvis only will be the answer, but I'm searching for reference. The reference is still searching. So let us skip this question as of now. If any of you know the answer was there, 18 years old age was there in this question means, please remember, if the question is 18 years old patient, the question is there, answer will be herniatomy. Please remember, less than 18 years, we can go only for herniatomy. So if the question is having 18 years patient, definitely the choice will change. If the age is not mentioned, it is, you can go for hernioplasty. Seeing this patient's abdomen, you can see is an old fellow or a young fellow. Okay, that's why. So wide pelvis will be the correct answer. Let us see any reference. If you find out, please tell me later. Okay, I'm searching for reference. It is not there in Bailey. Let me search in Sabiston and find out later. 65-year-old male patient presents with complaints of 7 months of white lesion between gingiva and buccal mucosa. He had history of tobacco chewing for more than 30 years. What is the management of this lesion? So please remember, this is a classical question. They're asking, what is the point about leukoplakia? The question is a concept of leukoplakia. This question, leukoplakia, has been asked multiple times in your exam. But what we usually do in our class, we will tell white patch. So even I have taught like that only in FMGE exam. I will not say no. In leukoplakia, what we will do? You will tell white patch is seen in the oral cavity is leukoplakia. It is pre-malignant. Okay, it is pre-malignant. That's all. We will stop with that. And maximum we will tell, we will have to do biopsy to confirm the lesion. That's all. So now this question is, you can answer this question only you understand everything in detail. So this question is telling, there are multiple choices. What is the management of this lesion? Stop tobacco chewing and do not bother the patchy lesion. Wrong. Because this lesion is pre-malignant. You know, the percentage of malignancy has been updated in Bailey and Love. It is from 1.5% to 30% risk of malignancy is there in leukoplakia. Electrocoagulation with chemicals was done once upon a time. Now we are not doing that because we will not know whether it is malignant or not. Steroid and vitamin supplements are not essential points here. So the answer here should be excision of the white plaque-like lesion. This is a line from Bailey and Love. The risk of malignancies in oroplakia is 0.13 to 34%, 0.1 to up to 34%. Biopsy of lesion is advocated for pathological diagnosis to assess the degree of dysplasia or presence of malignancy of the lesion. I'm sure that NEET PG aspirants, those who are going for exam next month, are assessing yourself how much you are able to make the answers. If you can make 35 questions in this 48 questions, I'm sure you can easily crack the exam. Okay, so keep following the questions. Definitely, these are highly expected NEET PG questions. 60-year-old female patient diagnosed with papillary cancer visiting you for an opinion for undergoing total thyroidectomy. What will you do for this patient? See, these are all, I'm telling you, this is a typical, you all should understand this is NEET SS question, not even NEET PG question. This is a NEET SS question. Let me write the protocol, what we used to teach in NEET SS. This is what we used to teach in NEET SS. So when a papillary cancer patient comes, see, this is a patient, this is a protocol. This is a question based on protocol. Papillary cancer thyroid patient coming to you. What we will do? We will immediately do total thyroidectomy. So that is done. If there are nodes, we will also do a modified radical neck node dissection. Now procedure is completed. After 4 weeks, we ask the patient to come back to us for doing one important investigation. What is this? Anybody? What is the important investigation we will do after the patient comes to us with the total thyroidectomy? This is the concept you should not forget. We will do radioactive iodine uptake study. For what? For what purpose I'm doing a radioactive iodine uptake study? Anybody can you tell me? Yes? Sorry. So radioactive iodine uptake study is done to look for METs, to rule out METs. Now you should ask a question, sir, what is this? You are not ruling out the METs before doing thyroidectomy. Now only you are doing. Yes, the reason is very simple. The reason is because when the thyroid gland is there, when I give iodine, radioactive iodine, it will be taken by the thyroid gland only. It will not be taken by whatever METs patient is having. It will not be taken by the anywhere. It will be only taken by the thyroid in the neck. Therefore, what should I do? Remove it out. Remove it out. Then only I will do this test of radioactive iodine uptake study. So on radioactive iodine uptake study, if there is METs present, what will I do? I should do a radioactive iodine ablation. See, there are two terms you should not get confused. Uptake study was done with the help of, uptake study is done with the help of 123 iodine. Ablation is done with the help of 131 iodine will be given for ablation of the tumor. And after ablating the METs, we will keep the patient under follow-up. Follow-up is done with the help of tumor marker thyroglobulin for papillary cancer, not for medullary cancer. Medullary cancer, we have a different tumor marker known as calcitonin. So here we do thyroglobulin number 1. Number 2, please don't forget thyroglobulin is one tumor marker. Number 2, very important point you should do is TSH suppression therapy should be given. So we have to suppress the TSH level because TSH is one of the important dangerous problem known as causing recurrence. High TSH is a cause of recurrence. Please don't forget. Therefore, we should give TSH therapy. Don't forget this point. Okay. This is the question they have asked. Now tell me the answer. What will you do regarding this patient? Yeah, that's a very nice question. Dr. Apoptosis has asked a very nice question. What about PET-CT? PET-CT is having no role in thyroid cancer. I'll tell you why. So this NEET SS question, actually, what is done after undergoing thyroidectomy, what will you do regarding this patient is radioiodine study is the answer. For this question, radioiodine study. So some of you are asking PET-CT. Let me tell you, when will I do PET-CT? Why should I do a PET-CT? When there is a more sensitive investigation, radioactive iodine uptake study is there. Radioactive iodine uptake study is 95% sensitive for thyroid cancer. Yes, it is after thyroidectomy only. The answer is therefore B. So I'm telling you, this question is from this protocol. Total thyroidectomy done, followed by what is the answer? That is answer. In future, you can get after radioactive iodine study shows METs. What will you do? I will do radioactive iodine ablation. Ablation is done. What will you do? Follow up. On follow-up, what should I do? On follow-up, if thyroglobulin is increasing, please don't forget. On follow-up, if thyroglobulin is increasing, immediately I should do radioactive iodine uptake study. Again, if there is no METs in radioactive iodine uptake study in future, if thyroglobulin increase, radioactive iodine uptake study shows no METs, then I will do PET-CT. This is the only role of PET-CT. Only role of PET-CT in papillary cancer thyroid is this, in follow-up after long time. Okay, after long time. So this concepts and all I'm telling you, these are never ever taken by any faculty, even for NEET PG exams. So this is definitely a tough question for FMG students, because the moment you see, as soon as the question is being done after undergoing total thyroidectomy, what will you do? Most of us will think you will give either a chemotherapy or something else. But unless you understand this protocol, you will not answer this. So this is a concept related to, see, once upon a time, we had a questions like a patient came to you with a cancer in the thyroid, FNAC shows somoma bodies or orphan and nuclei. That image was given. Simple. We used to crack those questions easily. So the role of FNAC is no more. Already this surgery being done, no? So what should I do? FNAC is not going to be wrong. So this question, unless you know this concept, you cannot mark it correctly. 90% of them, those who have not known this concept, would have made wrong. Okay. This is the ionized question. A baby presenting with the condition shown below is a condition of cleft lip. You can see this is a cleft lip. So cleft lip is due to failure of fusion of medial nasal process and maxillary. This question is being repeated actually, though it is not repeated in FMG. It's a repeat NEET PG question. So NEET PG question, the cleft lip is due to fusion of nasal process and maxillary process are not fused. This will result. So this is nothing to discuss, but please don't forget, cleft lip or nose is due to failure of fusion of medial nasal process and maxillary process. Cleft palate inside is due to failure of descent of fusion of palatal shelves. It is due to failure of descent of palatal shelves. Most important risk factor for acute mastitis. Only thing I'm happy is always these FMG examiners never forget to ask question on breast abscess or mastitis. So this is a case of acute mastitis. What happens in acute mastitis? A lactating woman, there are cracks developing in the nipple. Okay, there are cracks developing in the nipple through which the baby's mouth, when they are sucking the milk, the bacteria will enter the breast. So this is the most common mechanism of this mastitis is via the cracked nipples. So this is the reason. Another interesting point is that, but this is the reason in less than 1 month after delivery. What is the reason? After 6 months. Can somebody tell me the correct answer? This is a line from Bayesian law. Up to 1 month only, it is because of the crack, the baby's mouth, the infection, like, yes, very good. Staph aureus going into the breast and causing the problem. Yes, Prince Davis, you are correct. Staph aureus enters and causes mastitis, going for breast abscess, etc. After 6 months, what is the reason? See, it's there in Bayesian law. See, new Bailey 28th edition has updated. After 6 months, it is due to biting of the nipple by the baby. The baby bites with its teeth because they start developing teeth. They start biting the nipple and they transfer the infection now. That is lying there in. See, the answer here is B, but don't forget this point is there. So this occurs in 2 stages. One at first month when the mother don't maintain proper steps, and at the time of weaning when the baby bites with the teeth. So one important point I want to tell you, especially for NEET PG aspirant, those who are going for exam, this question is highly expected MCQ for you this year. The point is about management of breast abscess. I'm seeing even now many faculties are teaching breast abscess IND. 27th edition itself is changed it. IND is no more a treatment for breast abscess. This is updated in 27th edition Bayesian law. Please don't forget this. Not IND is not the treatment of breast abscess. The treatment of breast abscess, Bailey says, ultrasound guided repeated aspiration is the treatment. What is the advantage? Why not we do IND? Because when I'm doing ultrasound guided repeated aspiration, the baby can drink milk via that breast. Baby can drink milk via that breast. So ultrasound guided repeated aspiration is the 27th edition update. You know what happened in 28th edition? So 28th edition question may not come for NEET PG this year, but I said it can come. They have mentioned very clearly. And the cavity is more than 3 centimeter or 30 ml in ultrasound. I will do one procedure known as the abscess cavity. No, I will put a ultrasound guided. I will put a vacuum suction catheter. If size is more than 3 centimeter or 30 ml, I will insert a vacuum suction catheter. This is a new concept. Even this is not there in old Bailey. vacuum suction catheter. Nowhere there is a word known as I&D. I&D is outdated treatment for breast abscess. Please don't forget it. Okay. So that's about the questions from head and neck and general aspects. We had around 9 questions in this chapter on head and neck and general breast, head and neck and breast. But out of the 9 questions, only 4 questions are basic questions. Only 4. 5 questions are totally new concepts and new questions. I'm sure if you are answering 5 out of these 9 questions in breast, you are going to get good mark. Okay. So now I'm going to my favorite area of GIT. So let us see what all they have done in GIT now, apart from other chapters. So we are going to GIT, gastrointestinal tract. The first question itself is a controversial, complicated, confusing question. So again, this is a controversial, confusing, complicated question to make most of the students wrong. So this question is very clear concept from Bailey and Love, but Bailey itself is not correct. Bailey itself is wrong. So there are 3 constrictions in esophagus as per Bailey and Love. They are seen at 15 centimeter, 25 centimeter, and 40 centimeter. 15 centimeter is cricopharynx. This is all of you know that correctly. That is the most narrowest part of GIT. Most narrowest part of GIT is at 15 centimeter cricopharynx. All of you know that answer. In early stage of mastitis or whatever mastitis, Dr. Apoptosis, mastitis is not going to be treated by any surgery. So we can only give them antibiotics. Okay, antibiotics are enough because that's enough. Only when abscess is formed, we are going to treat them. Up to 2 centimeters, some books say we can manage them conservatively. But for your exams, you have to aspirate. Thank you, Vivek. Thank you. Thank you so much. You keep so at 25 centimeter, please remember 25 centimeter, there are 2 structures which are causing compression. One is arch of aorta, then the next is left bronchus. This is like this. The picture is exactly like this. At 25 centimeter, you see arch of aorta as well as left bronchus. So this exam, they made a big controversial choice. Arch of aorta is also there in the choice, and left bronchus is also in the choice. So nobody will make questions like this to make the students confused. So among the 3 constrictions, which one to mark? Arch of aorta or left bronchus? Answer is given by Shackelford Super Specialty Gastro book. Shackelford says arch of aorta is at 23 centimeter. Left bronchus is at 25 centimeter. Please don't forget, this is from Shackelford. The answer for this question should be left bronchus is the best answer for this question. If you have marked left bronchus, 99% you are correct. But there are chances if the examiner has not read Shackelford, he might even keep arch of aorta as the choice. We don't know what will be the choice by the examiner. But ideal answer is, let me tell you again this question. What are the natural constrictions as per Shackelford are 15 centimeter, 23 centimeter, 25 centimeter, 40 centimeter. There are 4 constrictions. 15 is cricopharynx, 23 is arch of aorta, 25 is left bronchus, 40 is diaphragmatic constriction. See this picture from Bailey and Love. Bailey and Love says 25 centimeter as aortic and bronchial. Even they don't even mention left bronchus. So therefore, this question is not from Bailey. It is from Sabiston. Okay. Yes, this question is repeat MCQ, but the controversy is on arch of aorta or left bronchus. I will go for left bronchus should be the best answer for this question. So many people are claiming this as radiology question. No, it is a surgery question. 4 years old child is brought to casualty with the complaints of accidental ingestion of coin while playing. A chest X-ray of the child is given below. Which of the following is the management of this patient? So the only point you have to know from the lateral view is it is not a tracheal foreign body. It is an esophageal foreign body. So in this view, you cannot find out. In this view, you cannot. AP view not at all useful for foreign body. AP view, if somebody is giving, they are totally trying to confuse you. So please remember, it is not, AP view will not help you to know whether it is a bronchus or esophagus. You should always need a lateral view. In the lateral view, you can see the gas shadow. Bronchus gas shadow will be going like this. So bronchus, tracheal gas shadow will be there. And behind that, the foreign body will be seen. So this picture on lateral view is showing like that. The foreign body is in the esophagus. So I'm not putting a perfect image, but this question is esophageal foreign body. Therefore, Heimlich maneuver, tracheostomy, bronchoscopy, all three are gone. Answer is A. Okay, answer is A. It's an esophageal foreign body removal. Now, let me tell you a few points about foreign body in esophagus. So, foreign body in esophagus, most common foreign body in children is coin. In old ages, dentures. Dentures, the old fellows, they have a denture that will fall down. So, and if they ask you what is the overall most common foreign body in esophagus, anybody can tell me the answer? Overall, the most common foreign body in esophagus is food. Food impaction. The food can get impacted and it will be there in the esophagus. Food impaction. You have to take 7-Up or Pepsi, you should drink it. That is a treatment for food impaction. So food impaction is very common foreign body. You have to take Pepsi or 7-Up and dissolve it. So in children, the commonest foreign body is coin. And in old age, the commonest foreign body is dentures. So what should I do for a coin and denture? Both of them should be retrieved by endoscopic retrieval. So in both these cases, if they are going into the stomach, what will I do? If coin is there in the stomach or denture is there in the stomach, what will I do? Then also I will remove it by endoscopy. If it is in the stomach also, I can remove it by endoscopy, but nothing to worry. But if it is gone beyond the pylorus, coin is gone beyond the pylorus, what will I do? Coin gone beyond the pylorus, wait and watch. See, don't forget this concept. This is what I'm telling you. You should stop reading as one-liners. You should understand the concept. A baby coming to you swallowing a coin. What should I do? Swallowing a coin, I will first of all do endoscopy and remove the coin from the esophagus. What will you do if the coin is in the stomach? Then also I will try to remove it by endoscopy. If it has crossed the pylorus, endoscopy cannot access. So I can wait and watch because most of the time the coin will come out. This is for coin. If there is a button battery, highly expected NEET PG question. Button battery swallowed by the baby is in the esophagus. What will I do? If it is in the stomach, what will I do? If it has gone beyond pylorus, what will I do? Esophagus, remove, immediately remove, don't delay. Stomach, actually no need to actually remove, but we have to examine esophagus. Pylorus, wherever it has gone, no need to remove, but examine esophagus. Why I'm again and again mentioning only about esophagus? Only those who have read Bailey and Love will know this. Button battery is nothing but alkaline battery. So alkaline battery can cause liquefactive necrosis of esophagus and perforation. Damage of the esophagus might have happened. To find out that damage, endoscopy is a must. Button battery removal must. Okay, if it is possible to remove it as early as possible. Even if it has gone to the small bowel, we don't operate and remove, but we have to examine the esophagus because button battery will damage only the esophagus. It won't go and cause perforation of the colon or small bowel. If at all, it will cause damage. It will cause damage of only esophagus. That is why we want the children not to play with the button batteries. More dangerous. Okay, please don't forget foreign bodies. Okay. Yes, it causes alkali damage. It is known as liquefactive necrosis. It is an alkali. Button battery is an alkali. We call it as alkaline battery, no? That's what. So this question is a simple question. Patient comes to OPD with complaints of pus discharge and after further investigation, it is known as fistula in ano. What is the gold standard investigation? Answer is MRI. Straightforward question. You should not make mistake in these type of questions. MRI is the latest investigation of choice. So, okay, it was the latest investigation of choice. MRI fistulogram. So MRI fistulogram. On MRI, what is the classification we used to see in fistula? The classification is Park's classification. Park's classification of MRI fistulogram. Please don't forget. Certain terms in fistula, you should not forget Park's classification. What is Goodsall rule? All these are very basic questions for NEET PG exam. Goodsall rule is anterior fistulas drain straight, posterior fistulas form a horseshoe tract and drain at 6 o'clock. Anterior fistulas, straight tract. Okay, posterior fistulas at 6 o'clock. Don't get confused in this. Okay, Goodsall rule is a rule. used for identifying the inner opening of the fistula. Inner opening of fistula can be identified by help of Kutzall rule. So Park's classification, don't forget, there is a very important thing that you should not forget. Intersphincteric fistula, transsphincteric fistula, suprasphincteric fistula, extralevator fistula. There are 4 types which can be found with MRI. So extralevator, all those things we can be found only with the help of this MRI fistulogram. Okay, that is correct. Kiran Jack is asking rigid flexible endoscopy. Actually, there is no more rigid endoscopy available in practice. That is an excellent question. No more rigid endoscopy available in practice. Only rigid sigmoidoscopy is still available. Rigid endoscopy is abandoned. Why? Rigid endoscopy is no more available because it can cause esophageal perforation. With the flexible scopy itself, I can excellently remove the point. Flexible scopy with the instruments are there. We can remove it. Very good, excellent, Dr. Knight. That is correct answer. If the anterior tract is more than 3.5 centimeter, very interesting exception. If the opening is more than 3.5 centimeter, that fellow also will open posterior only. That is an exception to Kutzall rule. Exception to Kutzall rule is if the opening is 3.5 centimeter, not 3 centimeter. It is also an exception. So Bailey and Love says short tau inversion recovery MRI. This is a latest term used in Bailey and Love. Short tau inversion recovery MRI. You should understand what is this from radiology faculties. It is a fat suppression technique of MRI. Short tau inversion MRI known as STIR MRI. So it is a fat suppression technique. Just understand from radiologist what is it. But this question is highly expected, updated 28th edition question. Okay. So this is again a simple question from child book score. All of you know this again a repeat question for a FMGE exam. That is, I think most of you will be knowing the mnemonic BAPI. So bilirubin, albumin, ascites, prothrombin time, encephalopathy. So please don't forget, simple question. So BAPI is a mnemonic. So most of you would have answered this question correctly, I think. Easy question. So which of the following procedure is having least chances of recurrence? This is again a repeat question. So GIT was comparatively easier. Most of the questions are repeat questions. Least chances of recurrence and high chances of recurrence. There are 2 questions in this question on least chances of recurrence and high chances of recurrence. I don't know whether the question was asked as high chances of recurrence or least chance of recurrence. Only you should know that. But please understand the 4 procedures we do for. There are 4 procedures which are done for. I want to tell you 4 procedures. I'll tell you 4 procedures for simple 4 procedures. I have just given outline. You should understand what are those 4 procedures. Please understand the 4 procedures used for peptic ulcer disease. So I'll just give a brief outline. This is left anterior vagotomy, anterior vagus now. This is right posterior vagus now. So the first important commonly done procedure by most of us is cutting this here and here. This surgery is known as truncal vagotomy. So whenever I do truncal vagotomy, I will also do a GJ. So this is the commonly done procedure. Most common done procedure is this. So what are the other procedures? Another surgeon, he used to cut only the posterior vagus. Sorry, anterior vagus or posterior vagus, and it is selective vagotomy type of procedure. Selective vagotomy. It is no more done. Selective vagotomy is no more done. Now, the latest procedure done by Western people, not in India, is to cut all the branches going to stomach alone like this, preserving the pylorus branches. Pylorus branches preserved. That is known as crow's foot. Crow's foot is preserved, only the gastric branches are cut. This is known as highly selective vagotomy, HSV, also known as parietal cell vagotomy. Parietal cell vagotomy. So this is second question number 3. The last question, which is having the lowest recurrence, is after doing vagotomy, I will remove the acid producing part of stomach, known as antrectomy. Truncal vagotomy with antrectomy is not done anywhere, but it is having the lowest recurrence. Highest recurrence is high selective vagotomy. Please don't forget, highest recurrence is high selective vagotomy, lowest recurrence is Truncal vagotomy with antrectomy. So if you can tell me the correct choice, I can tell you what is the question. But if it is, you just remember high recurrences, high selective vagotomy. Low recurrences, truncal vagotomy with antrectomy. With antrectomy. Don't forget this point. Okay. One more missing vagus branch. Which branch you're telling? So only the crow's foot or nerve of Latrajet, this is known as nerve of Latrajet, should be preserved. Don't forget this. That is preserved in this case. So a homosexual, again, this again a repeat question. So most of the questions in GIT are luckily repeated. So a male homosexual patient with a painful defecation, not reduced, and has foul smelling cauliflower-like growth. On biopsy, diagnosis is squamous cell cancer was made. What is this biopsy showing squamous cell cancer? Yes. What is this squamous cell cancer? It is the squamous cell cancer. The regimen used is Negro regimen. Negro regimen. Negro regimen is nothing but chemotherapy plus radiotherapy is known as Negro regimen. This question is again a repeat question. Negro regimen is the regimen for squamous cell cancer of anal canal. Please don't forget, squamous cell cancer of anal canal is chemoradiotherapy known as Negro regimen. And if there is an adenocarcinoma mentioned, adeno cancer of anal canal mentioned, what will I do? Adeno cancer of anal canal is mentioned. What will I do? I should go for APR. Please don't forget. Luckily, the question was mentioning squamous cell cancer, which is the commonest cancer, Negro regimen. So very common in HIV patients, they have this type of problems. Okay. Please don't forget this point. So a baby was brought to emergency on second day of birth with excessive frothing and respiratory distress. Excess is shown below with the coiling of Ryle's tube. A baby was brought to emergency on second day with excessive frothing, and X-ray is shown below with the coiling of Ryle's tube. What is this coiling of Ryle's tube? Coiling of Ryle's tube is classical clue for the question. It is tracheoesophageal fistula. There are two important questions I always used to tell. If you pass 5-fluorouracil with mitomycin, Raj, the question for Negro regimen, what drug will you use is 5-FU with mitomycin. Please don't forget. The chemotherapy used is 5-fluorouracil plus mitomycin chemotherapy plus up to 50 gray radiotherapy will be given. Up to 50 gray radiotherapy and 5-FU mitomycin are used. Okay. So this tracheoesophageal fistula, two questions. When I'm passing the Ryle's tube enters the stomach. When I pass the Ryle's tube, it enters the stomach. It enters stomach. It is normal. If it enters the chest, what does it mean? The Ryle's tube entering the chest is diaphragmatic hernia. These are the various questions. Entering the stomach, and we have to confirm it by pH testing. Entering the chest is CDH. It is passed through nose, coming out through the mouth is coiling. Coiling is tracheoesophageal fistula. So classical, simple, repeat question. 40 years diabetic patient presents with the DVT with a necrolytic migratory erythema. The clue is here. Necrolytic migratory erythema and diabetes DVT. So this again a repeat question. D, 4D. Dermatitis, very important feature is dermatitis and diabetes. What is this case? It's a case of glucagonoma. Dermatitis is nothing but necrolytic migratory erythema due to decreased amino acid in these people. Why they develop skin problem? Because of decrease of amino acid. Diabetes because glucagon, naturally sugar increases. Then DVT, deep vein thrombosis, exact mechanism is not known for why there is a DVT happening, but factor 10 is increased in glucagonoma. Dermatitis is because of decreased amino acid. Factor 10 is increased causing DVT, and another D is for some delirium and other problems, some psychiatric issues, delirium. So, but please don't forget, this is glucagonoma. Most of the glucagonoma are malignant and they are seen on head of pancreas. Most are malignant and they are seen on head of pancreas. It's a repeat question. So, increased tone of LES in Achalasia cardia is due to. So, this question I'm not sure with the choices and the other things, but this is a line from Bayesian law. Why there is Achalasia LES tone is increased? The answer is clearly given in Bayesian law. There are two answers correct here. Decreased nitric oxide. Nitric oxide is a relaxant. So that is less in the neurotransmitter end. But there is a better answer there in Bailey and Love. Absent myenteric plexus. Absence of myenteric plexus. If it is Meissner's plexus mentioned, it is wrong. But if myenteric plexus mentioned, that is also correct. So there are two answers in this question. But from latest Bailey, see what is writing. Bailey says etiology is uncertain. It is postulated that loss of inhibitory ganglion cells in the myenteric plexus possibly related to viral-induced autoimmune effect. So the mismatch of excitatory and inhibitory neurons results in failure of LOS to open. So histology shows reduction of ganglion cells. So therefore, there is a point, this D can be an answer because all the old books have removed the neurotransmitter nitric oxide in LES is decreased. It is an old concept. It's an old concept. New concept is there is absence of inhibitory neurons in myenteric plexus. This is a new concept. In fact, this is only line written in Bailey and Love. Bailey and Love never writes about nitric oxide. So this question is increased tone of LES can be either C or D. Don't know the answer exactly. We have to wait and see what is happening in this choice. Okay. So this is from Bailey and Love. They are saying absence of myenteric plexus was not there means you can go with C. If this absence of myenteric plexus choice is not there means Prince Davis is telling we can go for decreased nitric oxide. Nitric oxide is decreased in the LES. That will be the better answer in such case. A baby presented, this again an old repeat MCQ, a baby presented with congenital hypertrophic pyloric stenosis. False statement is all of you know the answer for this question. Non-bilious vomiting, ultrasound is 100% sensitivity caused by hypertrophy of not longitudinal muscle. So in pylorus, there are two muscles. This is one muscle. This is known as circular muscle. And when you go deeper, you can see outer, there is longitudinal muscle. This is longitudinal, outer longitudinal, inner circular muscle. So these are the muscles of pylorus. So what should I do is I have to cut the circular muscle. That is the most important thing. So the hypertrophy is for circular muscles, not longitudinal muscle. The problem in this infantile hypertrophic pyloric stenosis is circular muscles, and you all know very well the electrolyte imbalance, hypokalemic, hyponatremic, metabolic alkalosis is seen in this case. So question number 30 is absolutely easy question C. So again, another easy question. So GIT, all the questions are easy. An alcoholic patient presents with epigastric pain radiating to the back. Amylase is increased. When amylase is increased, no doubt answer is acute pancreatitis. It is a repeat question. So pain radiating from epigastrium to back is pancreatitis, no doubt. Okay. So in GIT, we had around some 12 questions. All the questions are easy. Identify the structure shown in the barium. In exam, they showed this structure only. So please remember, in exam, the picture marked was this. This is a duodenal cap. So duodenal cap. Pylorus will be narrowed. Please understand, most of the students have wrote pylorus. Pylorus will be like this. It's narrowed. Congenital hypertrophic pyloric stenosis also, it will be narrowed, no? Same way it will be narrowed. And then comes the first part. The first part looks like a bulb, like a duodenal bulb. This is duodenal bulb. Duodenal bulb is first part of duodenum. It will be looking after coming out of the pylorus, we will see as if we have entered a big structure that is duodenal bulb. The answer is duodenal first part, not pylorus. Many students wrote it as pylorus. It is wrong. It is not pylorus. Most common indication for splenectomy in hemolytic anemias. So please understand 3 questions in this. Splenectomy, 3 questions are there. Most common indication overall, what is answer? It is trauma. Most common indication elective. Answer is ITP. Most common hemolytic indication, like hemolytic anemias, like sickle cell anemia, hereditary spherocytosis, hereditary elliptocytosis, etc. The answer is hereditary spherocytosis is an answer C. So this is a simple question. For gastro questions are all not much tougher questions. So all the 12 questions came from GIT and HPP are all little easy question. Okay. So all the questions. Only thing I was very much upset is after reading the question paper is there is no question from which chapter? Can you tell me? Gallstones. No question came from gallstones in an FMGE exam is a highly unacceptable thing. So because gallstone is such an important topic, we take this class for 4 hours, gallbladder and gallstone chapter, 3 to 4 hours we take. But no single question came. MRCP, ERCP, gallstone related, nothing came. So it's one of the worst paper because whatever we expected, we are not asked. Okay, we are not asked in this exam. So related to vaccination, if you want, Zafar is asking vaccination points. So to prevent OPSI, to prevent opportunistic post-splenectomy infection, there are 3 vaccines should be given. PPV 23, pneumococcal, H influenza vaccine, meningococcal vaccine. So most simple basic question is, all these 3 are given 2 weeks prior in elective case. In elective case, all these 3 are given 2 weeks prior. In emergency case, what will I do? In emergency cases, I will give PPV 23 in the OT itself. OT, when the patient is coming out, we have to give it. OT itself, we have to give it. So other 2 are given within 14 days. Given within 14 days. So please don't forget these points. So what about the vaccination? Please don't forget. Okay. So now we are going to urology. So urology, we always know FMG exams always ask questions from urology more. Yes, this year also they have never failed to ask questions. They have asked 8 questions from urology. All the 8 are controversially complicated questions. You're going to see them. They are not easy questions. 8 questions came from urology. All the 8 are new questions. That is interesting. Another point. 20-year-old male patient comes to you with the left testicular cancer, presented to the hospital for follow-up. What is the first node involved? So this is a simple, straightforward anatomy question actually. Unless you have read this, you cannot answer this question. Let me tell you what is this point related to. So all of you should understand one basic anatomy. So this is the scrotum. This is right testis. This is left testis. So this right testis came from right lumbar region. Left testis came from this place only. This all came from here. And this is IVC. This is aorta. When I ask you what is the sentinel node of penis cancer, you will immediately tell it goes to inguinal node. So you all know easily penis will spread to inguinal nodes. All of you know the answer for that. So penis will spread to inguinal node. That is the first node. Breast will spread to axillary node. Oral cancer will spread to neck node. So this is all you all know. These are the first nodes involved. Same question is asked. They are asking a question which is first time asked in an FMG exam. If there is a cancer in the left testis, where it will spread. If it is in the right testis, where it will spread. Please never ever forget for your lifetime. The cancer from this testicular tumor will spread to right side testis will spread here. Left side testis will spread here. Okay, left side testis will spread to para-aortic nodes. Right side will spread to inter-aortocaval node. See, never forget this hereafter. That's all. That's all we can do. The exam is over. Questions being asked, which is new, totally new question. They are with the intention of causing more trouble to the FMG students. Its right side is inter-aortocaval nodes. Left side is para-aortic nodes. Even many NEET PG aspirants will be seeing this question first now only. So right side is aortocaval node, left side is para-aortic node. So the question is asking left side. So I am going for a para-aortic node. If the right side was asked, I would have gone for a pre-caval node. The left side is para-aortic node. So it's simple, straightforward question. Okay, this is the first node involved in obturator node. In prostatic cancer, it is obturator node. So each cancer has a one node. Prostate and bladder. In prostate and bladder, the first involved node is obturator node. Okay. See the second question. Another complicated, highly causing confusion among the students is, which of the following does not lead to bilateral hydronephrosis? So this is a urinary tract. 2 kidney, ureter, bladder, urethra, penis. So when there is bilateral obstruction of the bilateral hydronephrosis, when both are enlarged, the problem will be starting from here. Any problem here, any problem here, any problem here. Even problem here like phimosis can cause bilateral hydronephrosis. Urethral stricture can cause hydronephrosis. BPH can cause hydronephrosis bilateral. Posterior urethral valve can cause bilateral hydronephrosis. So any problem happening distal to the bladder only will cause bilateral hydronephrosis. What is this retrocaval ureter? Retrocaval ureter is a condition in which ureter goes behind the IVC. This is IVC. This fellow takes a curve behind IVC and comes out. This is seen only on right side. Please don't forget, retrocaval ureter is seen only on right side. So only causes right side hydroureteronephrosis, giving a deformity known as shepherd hook deformity. Shepherd hook deformity is the answer for this question. So please remember, interesting questions are all very good, standard, no doubt, but not for FMG standard. This is another question. Ideal management of this case. This is actually a radiology question. If you can identify this is the problem, the diagnosis is over. What is this? Many students got confused whether it is a ureteric stone or a kidney stone, staghorn stone, like that. Most of them get confused, but it is simple ureteric stone. Ureteric stone. Actually, what in the exam was given was actually like a ureter with multiple stones in the ureter was the question I heard. 1, 2, 3, like that. Multiple ureteric stones were mentioned by some students. There are multiple stones, not ESWL. We cannot treat ureteric stones by ESWL. ESWL can treat only upper ureteric stone. If at all, very rarely, that also not always. Mid ureter and lower ureter, it will not be possible. Therefore, ureteric stone in the mid and lower ureter, the treatment is ureteroscopic removal by using a special basket known as Darmia basket. Using a basket known as Darmia basket. If there are some NEET PG aspirants preparing, I want you to know two important terms from Bayesian law. Anybody can tell me what is push bang technique? Push bang technique. From the students who are preparing, please tell me what is push bang technique. If there is renal stones was not there, as some students are doing ureter as well as renal stones are there. So renal stone is there means we have to go for ESWL plus ureteroscopy. But whatever it is, next done will be ureteroscopy only. We have to immediately do ureteroscopy only. So anybody need PG aspirants, tell me what is this push bang technique. And anybody need PG aspirants, please tell me what is stain stress. What is the complication stain stress? So many interesting questions are there in urology. Push bang technique is very good, not to the urethra, Tejakumar. It is, see, understand this. There is a stone in the ureter, like what you saw in the image. There is a stone in this mid ureter or in the upper ureter, somewhere in this area. So not able to remove by ureteroscope. What we will do is, we will push the stone back into the renal pelvis, into this pelvis. So we will push the stone back into the renal pelvis. And what we will do later? We will break it by push back to pelvis and break by ESWL. That is push bang technique. What is stain stress? A stone is sitting all along the ureter like this. Multiple stones along the ureter like this, following a complication of ESWL. On ESWL, the big stone is broken and it obstructs the entire lumen. Okay, that is the point here. ESWL is seen multiple stones all along the tract known as stone street. That is known as stain stress. So for ureteric stone question, if there is only one choice, ureteroscopy, go for it. Definitely in future we will do ESWL, but ESWL, if you are answering ESWL for even if this question, some of you are having a posting that it is ESWL. So even if there is stone in the kidney, let me tell you, if there is stones, I will tell you one interesting scenario. This is very basics of ESWL, which is usually taken for NEET SS questions. Please understand, this is usually taken for NEET SS. If there is stone in the kidney, if there is stone in the ureter causing obstruction, obstructed stone in the ureter, what is the treatment for this case? Let us assume this is a 1 centimeter stone and there is stone obstructed in the ureter. What is the treatment of choice for this case means? Please understand, first I should do ureteroscopy and remove the stone. Okay, ureteroscopy and remove the stone. Because why, you can ask, sir, why are you removing the stone? Why not you break this stone? ESWL, this is a line from, very important line from super specialty books. ESWL is contraindicated in obstructed urinary system. If there is obstructed urinary system, I cannot do ESWL. I should only do ureteroscope. Then only after putting a stent only, then I will go for ESWL. So the best answer, even if it is going to be a stone in the kidney and ureter also, the answer will be ideal management is ureteroscopy followed by ESWL, not ESWL. ESWL will not come at all. If there is ureteroscopy is not there, there should be in some other answer known as RIRS. I don't know whether it is mentioned or not. RIRS. RIRS is a new technique in which with the ureteroscope, we will go inside, remove all the stones, kidney stone as well as ureterous stone. This is the latest answer which might be asked only for INI set exam, known as RIRS. RIRS is retrograde, see, retrograde intrarenal surgery. I don't know why the examiners are going this depth in urology, because urology is a super specialty topic. They should not go in depth in this. Ultrasound was there in the option. What you are going to do with an ultrasound? Because already we have a CT scan. CT scan is the diagnostic of stone. Ultrasound is not going to be useful. So if there is no option of ureteroscopy, you have to see that must be something you are missing in the question. Definitely with such case, ERs, I can guarantee one point, that is ESWL cannot be done. I can guarantee that. TCNL is not done for ureteric stones. So if ureteroscopy is not there, there should be some other choice like RIRS, something will be there. You must not miss it. See, some of them are mentioning ureteroscopy is there in the choice. So if ureteroscopy is there, that's the correct answer. So another new question. All of you would have seen IVP image of horseshoe kidney. All of you would have seen IVP image of horseshoe kidney like this many times, like a flower vase appearance. Here there is a question of horseshoe kidney, CT scan they have kept. See how they wanted you to cause confusion. Unless you identify this is a kidney, you cannot know this is the horseshoe kidney. This is a horseshoe kidney. Okay. What is this? Now it's a time now you should also read the choices. What do you mean by pancake kidney? What is pancake kidney? Pancake kidney is a kidney in which this is the normal kidney. No, this is a normal kidney. This is horseshoe kidney. The fusion of lower pole at the level of L4 vertebra is known as horseshoe kidney. When the upper pole is also fused like this, see, it looks like a donut. Now the kidney is like a donut. This is known as a donut kidney or pancake kidney. So donut kidney or pancake kidney. Oh, very good. That's correct choice. Kamru Zaman URS, if it is mentioned there, that's correct. So this is a horseshoe kidney. Most probably, if you have read radiology question, probably you would have answered this question correctly. Horseshoe kidney. So this is a simple question on bladder cancer with involving the muscle. So there are two types of bladder cancer. Bladder cancer is of two types. One is non-muscle invasive cancer. Actually, it's a one-liner. Non-muscle invasive cancer and muscle invasive cancer. Simple answer is there for this. In non-muscle invasive cancer, we can use transurethral resection of bladder tumor. In non-muscle invasive cancer, the answer is transurethral resection of bladder tumor. Muscle invasive cancer, we cannot do this. Transurethral resection of bladder tumor followed by intravesical BCG or mitomycin is used only for non-muscle invasive bladder cancer. If it is a muscle invasive, the treatment is totally different. We have to remove radical cystectomy, means including prostate only. Radical cystoprostectomy is the treatment for muscle invasive cancer. So go for B, because the answer is very clear. The answer is very clearly mentioning involving muscle. Involving muscle, there is no role of intravesical, nothing is useful. Transurethral, nothing is useful. We have to go for cystoprostectomy. It's a bladder cancer. Please don't get confused in this. Bladder cancer always surgically treated for muscle invasive. In BPH causing urinary symptoms, now let us assume an old man coming to you with a BOO. I'm writing the protocol for BOO. So BOO protocol, bladder outlet obstruction protocol due to BPH. Patient is having symptoms of urgency, hesitancy, retention, etc., etc. There are so many symptoms or so many problems are there in this. So now, very important point I want to tell you here is, once you diagnose it's a benign prostatic hyperplasia, what should I do now? I should now go for uroflowmetry. Uroflowmetry should be done immediately. If the flow rate is less than 10 ml per second or voiding pressure is more than 80 centimeters water, it is definitely needing a treatment, needs treatment. So there are two modes of treatment. Initially, when the patient comes to us, we will start them on medical treatment. Medical treatment, all of you know the answer very well. Alpha blockers are the drug of choice which will act immediately, prazosin, terazosin, etc., the old drugs. Now we use alpha 1A blocker to prevent postural hypotension, that is tamsulosin. Should be started the moment you see this old man. When you see a old man with this thing, we should immediately start them on tamsulosin. Some of you might think, what about this 5-alpha reductase inhibitors? 5-alpha reductase inhibitors will act only after 3 months, it will start its action. It will only shrink the prostate, whereas tamsulosin relaxes the sphincter. So therefore, easily they pass urine. Immediate response is seen with tamsulosin. So 5-alpha reductase inhibitor is done for action starts after 3 months. So medical treatment is given for most of the patients. We don't give surgical treatment now. Surgical treatment is indicated. The gold standard surgery now is TURP, transurethral resection of prostate. So in this question, what is causing first to do is the question. So they didn't ask what is the best option. They are asking first to do. So go for alpha blocker will be the best answer in this question. Sildenafil is not used for this BPH. Sildenafil is used for erectile problems. It's a Viagra. Viagra is sildenafil. We should be using it for erection problems. It's a dilator, but problem is it's an erectile. This is okay, erectile issues. So BPH causing urinary symptoms, first to do is alpha blockers. So next question is pediatric question, pediatric surgery also. So regarding nephroblastoma, all are true except. So I want to tell you some differences between nephroblastoma and about the neuroblastoma. All of you, please don't forget, especially if you are some NEET SS, NEET PG aspirants here, please don't forget nephroblastoma versus neuroblastoma. Most important points. Neuroblastoma versus nephroblastoma, which is common among these two. So the most common is neuroblastoma. Most common abdominal big mass, abdominal tumor in children less than 5 years. So nephroblastoma is not that much common, but it is commonest kidney tumor in children. First point. So neuroblastoma is a tumor arising from adrenal medulla. It arises from medulla. Whereas nephroblastoma is a tumor arising from the kidney itself. It arises from kidney. So please, therefore, don't forget the neuroblastoma will easily cross the midline. Crosses midline always. The tumor will become bigger and crosses midline always. Nephroblastoma occasionally crosses midline. That much bigger size it should be there. Occasionally crosses midline. Which among these two will cause more of metastasis? Metastasis is more common with neuroblastoma. It produces brain mets, liver mets, lymph node mets, bone mets. Everything is produced by neuroblastoma. Mets in nephroblastoma, most common yearly to yearly mets of nephroblastoma. Many patients, 10% of the cases, when they come to hospital itself, they will have this mets, that is lung mets. Lymph node mets are rare. Lymph node mets are also present, but it is rare. Hematogenous mets are also present. That is also present. How to differentiate them on CT scan? Very important. Calcification is present in neuroblastoma. Calcifications are present, and there is chances of neural invasion is present. All these are seen in neuroblastoma. Nephroblastoma, venous invasion is seen. Please don't forget, venous invasion is present in nephroblastoma. Why this is very important? Because both of them will have the same huge mass in the abdomen. Both of them will come to you with a huge mass in the abdomen. So now neuroblastoma is more dangerous. Urinary VMA might be used to diagnose it. Drooping lily sign seen on IVP. Drooping lily sign is seen on IVP. Please don't forget, all these are essential points I want to remember between neuroblastoma and nephroblastoma. With this, you have to understand what is the latest treatment of nephroblastoma. Wilms tumor, what is the treatment? Wilms tumor, there are two types of treatment available. One is SIOP protocol. Another is NWTSG protocol. SIOP protocol is a protocol which advises chemotherapy followed by surgery. This is the protocol, SIOP protocol. Chemotherapy followed by surgery. NWSD, National Wilms Tumor Study Group protocol is surgery followed by chemotherapy. So you have to answer what is this, because I could not get the exact choice in this question. Hematogenous spread is seen, yearly lung mets are seen, chemotherapy followed by surgery done as per SIOP protocol, lymphatic spread is also seen. So all the answers are correct in question number 40. So if you have any other choice which is wrongly mentioned here, you can tell me, because this question I could not get the proper recollection. So the answer is, what is the points about these two tumors? I have given everything about the two tumors, neuroblastoma and nephroblastoma. I have mentioned everything about these two tumors. Okay. So coming up to the last few questions, 40 years old female patient presented with the pain in the left flank and hypochondrium. On examination, a mass of 4 centimeter was felt. Okay, please remember, a mass of 4 centimeter was felt. And kidney was belatable. The only tumor which will be belatable on the lumbar region is kidney, because kidney, the word belatability, belatable is a word used specifically for kidney. Belatable means, most of you might be knowing it. If I compress from back side, I will compress from upside. I can see both sides like a ball. If this is a ball, I can hit it here, it can hit it here. So like that, I can palpate from both sides. Belatable, bimanually palpable and belatable are features of kidney mass. So this question is a question on kidney mass. On examination, malignant cells are seen. What will be the next line? The question is asked. Next line of management. So this is a case of RCC. Let us hope it is a case of RCC, 4 centimeter size. So for 4 centimeter size, the treatment advises partial nephrectomy. Partial nephrectomy can be done for tumors less than 4 centimeter, and now even up to less than 7 centimeter, partial nephrectomy can be done. But before doing partial nephrectomy, we should assess the kidney function, assess the renal perfusion using DTPA scan. Because only if the kidney is functioning good, it is useful of doing partial nephrectomy. If the kidney is not perfusing properly, if there is a tumor infiltration and all causing the kidney is not having a good blood flow, we cannot do. So do DTPA scan followed by partial nephrectomy. Basically, intravesical BCG and all is not used because it is not bladder tumor. So that concept is gone. So it is not a bladder tumor. So you can forget that about the bladder tumor. Okay. So it is not a bladder tumor. So you please remember this is a renal tumor. So we had 88 questions from the urology. You can very well guess of these questions. Only 1 or 2 questions are easiest question. Otherwise, most of them are tough questions. So what is the gold standard treatment for varicose veins? Coming to the last 6 questions from other specialties. From other specialties, we had some 6 questions from vascular surgery. The old treatment of varicose veins is Trendelenburg operation. Old operation. Old operation is Trendelenburg procedure, in which what we do? We do saphenofemoral flush ligation, and we will strip the veins. And we will do stripping of the veins. Stripping of long saphenous vein and short saphenous vein is an old treatment. Now it is nobody. I am seeing no vascular surgeons even in my small town doing this procedure. The vascular surgeons are all doing the new procedure known as EVLA or RFA. So endovenous laser ablation or endovenous RFA. So the latest is RFA. That is the latest ablation. Radio frequency ablation is nothing but thermal ablation. That is the correct answer. Endovenous laser ablation or thermal ablation is the latest answer they are doing now. Okay, don't forget this. Now coming to this question on I'm watching on another channel, so I'm just seeing any issues. Which of the following is not a superior mediastinal mass? So mediastinal tumor is a very favorite topic. Most of the NEET PG aspirants will be knowing this. Even FMGE exam students, you know, most common mediastinal mass is what? Most common mediastinal mass is neurogenic tumors. So it is usually seen in posterior mediastinum. So most common anterior mediastinal mass is what? Anterior mediastinal mass is thymoma. Thymoma. Thymoma is an anterior mediastinal mass. Posterior mediastinal mass overall, as well as posterior mediastinal mass, the commonest is neurogenic tumor. Anterior mediastinal mass is thymoma. So what is this mediastinum? So please understand, this is the thoracic cavity, which we will not concentrate usually in lectures also. This is middle mediastinum containing the heart. Okay, this is heart. This is posterior, this is anterior, this is middle mediastinum. In middle mediastinum, you have the heart. Posterior mediastinum, we have the aorta and neurovascular structures. So therefore, any neural tumors will arise here only. Anterior mediastinum is relatively an empty area. So usually you'll get very rarely any masses. So this is superior mediastinum. Only common mass here is thymoma. This is superior mediastinum. Superior mediastinum is just here. The moment you enter here, it is superior mediastinum, where you can get thyroid enlarging insert, and anterior thymus can also enter here. Thyroid can enter here. Parathyroid can be seen. Parathyroid can be seen here. Among this, the least common answer is lymphoma. So thyroid, thymus, parathyroid can be seen in the superior mediastinum except lymphoma. Okay, lymphoma is the answer here. So question number 44 is a classical question. They would have asked very simplified question, but they made you make wrong by asking and confusing you. Please understand, 80 years old, that's a catch point here. 80 years old smoker. Most of you would have been stimulated by the word smoker and would have gone to Buerger's disease, because Buerger disease was our old common MCQ. So all of you will be stimulated. See, now also I'm seeing all of you are answering Buerger's disease. Please, I'm telling you, you stop your temptations. Temptations should be controlled. So FMGE exam students, you are appearing for exams, even for NEET PG aspirants, stop your temptation. When you are appearing for exam, all of you will get that mistake. That is, mistake is, you all will be stimulated to go and answer a very well-known old concept or very well-known repeat question. So Buerger's disease is a repeat question. So all of you will be stimulated to go and answer Buerger's disease. You should not answer Buerger's disease, because Buerger's disease, that means what? You are not knowing Buerger's disease completely. So Buerger's disease, what are the points of Buerger's disease? Let me tell you Buerger's, you won't answer that again. So Buerger's disease is having a criteria known as Shionaya criteria. What is this criteria saying? This criteria says Buerger's disease will happen only for age of less than 40 years, only for males, not for females. And they have only one risk factor, that is only one risk factor known as smoking. No other risk factor will be there like diabetes or coronary artery disease. And number 3, it will be bilateral and it will be infrapopliteal, just below the popliteal only. It can involve upper limb, also can be involved. Upper limb can be involved. So upper limb can be involved. Adjacent veins and nerves can be involved. So this is the 5 points of Shionaya criteria. It is bilateral, infrapopliteal lesion. Upper limb can be involved. Adjacent veins and nerves are involved. If any one of these is different, you should not follow this, because if more than 40 years, it is not Buerger's. If there are other risk factors, it is not Buerger's. If it is unilateral, it is not Buerger's. Please don't forget, these are very essential points. So therefore, this fellow is 80-year-old man. Okay, 80-year-old man with an bilateral gangrene of the digit is not Buerger's. It is atherosclerosis, not giant cell arteritis or Raynaud's disease. They are all very rare. So this is a atherosclerosis, because the history was also mentioning he had a history of coronary artery disease. So the answer is atherosclerosis. Please don't forget, atherosclerosis is very common. Yeah, that's we will always make this mistake. I'm telling you, most of the FMG students would have been stimulated and they would have all answered Buerger's disease. 90% of them would have answered Buerger's only. Only 10% of them, those who have understood this concept of Buerger will not happen in old age. It will happen only in young age people who are smoking. Okay, we'll answer that correctly. This is a simple question. A patient is done with the following procedure: his own skin graft. What is the type of skin grafting? This is SST, split skin graft of autograft. Same individual, same person. It is autograft. Xenograft is different species. Different species is known as xenograft. Allograft is what? It is between same species. Okay, same species is called as same species is allograft. Different species is Xenograft. From pigs, we get from pigs is known as xenograft. Allograft is from your relative. This allograft. You don't forget this. What is isograft? Isograft, I for identical twins, not non-identical twins. Please remember, non-identical twin is known as allograft. Non-identical twins are called as allografts. Only identical twins are called as I for I, isograft. Okay, isograft is only for identical twins. No one confused. Okay, this is very important. Isografts, you should not forget. Isograft is between identical twins. See, another question, classical question, stones, bones, abdominal groans, psychic moans. No doubt, primary hyperparathyroidism. The diagnosis is over, primary hyperparathyroidism from the history itself. No need to get confused from the picture. The picture is showing you a Brown's tumor. So which of the following investigation is used for the diagnosis? Technetium 19 mm scan is used. Ultrasound neck is used. CT scan is also used. I don't know what they want. Everything is used in this. Chestomy B scan, ultrasound neck, CT scan, everything can be used. So what is the answer they are specifically expecting? I don't know, but I will tell you the protocol in this. So the protocol for hyperparathyroidism. Let me tell you the protocol for hyperparathyroidism. A patient coming to you with a primary hyperparathyroidism. This is very important for NEET PG aspirants. Please focus on this. A patient coming to you with the primary hyperparathyroidism. Please don't forget, patient coming to you with the primary hyperparathyroidism. We will do ultrasound neck plus Cystemy B scan. Both will be done. Ultrasound neck and Cystemy B scan, both are done. Ultrasound neck, Cystemy B scan, both are done. So in the neck, if they show concordant images, means what? They both are showing, okay, there is a lesion in the left inferior parathyroid. There is an adenoma. Concordant images. If both are showing concordant images, I will go for surgery known as minimally invasive parathyroidectomy. Simple answer. If it is showing conservative, same problem means 3 centimeter incision I will make and only remove that tumor. 3 centimeter incision, I will remove that tumor. Simple answer. After removing the tumor, I will do Miami criteria. Miami criteria. What is Miami criteria will say? Miami criteria will say, after removal, the parathyroid hormone should decrease 50% of parathyroid hormone level should decrease in 10 minutes. In 10 minutes, it should decrease less than 50%. This is known as Miami criteria. If not decreases, what will I do? See, this is the protocol in the management of hyperparathyroidism. So Miami criteria says, if it is not decreasing, then I should go for a full neck exploration. Fully put a big incision in the neck. Bilateral neck exploration and remove all the 4 glands removed. All 4 glands removed and keep 1 gland in brachioradialis. That's all. Remove all the 4 glands and keep 1 gland in brachioradialis. Don't forget this point. So this is a simple protocol which can be asked for NEET PG also. So NEET PG exam, what are the investigations done? Ultrasound and Cystemy B scan will be done. Both will be done. So if there are concordant images, I will go for minimally invasive parathyroidectomy by a 3 centimeter incision. So if it's a Miami criteria says, if the 50% of the parathyroid hormone is decreased, it is okay. You have done a good surgery. You have removed the problem. If not decreases, you have to remove all the 4 glands and keep 1 gland in the brachioradialis by putting a big incision that is known as bilateral neck exploration. So this is for concordant images. Ultrasound and MIB having discordant image. What will I do? Means what? One ultrasound is showing lesion somewhere. MIB showing lesion somewhere. So discordant images, I should do next investigation, 4-dimensional CT scan and plan for bilateral cervical exploration. Remove all glands. So this is a simple protocol. That is why I'm telling you in this all are answers. Correct? I don't know what they want. In this question, technetium scan is used, ultrasound neck is used, CT scan is also used. MRI only is not there in Bailey and Lowe. All are there used in this. So please don't forget this. Yes, this is very important. Please don't forget this. So any doubts, we will be answering just 2 more questions. We finish and I will clarify your doubts. Please wait. A patient is having severe thunderclap headache. Actually, there is no word thunderclap, but severe headache which he has never felt in lifetime. No history of fever on antiepilepsy. Everyone would have answered this question. It is subarachnoid hemorrhage due to rupture of perianeurysm rupture. So no discussion needed for this question. It's a very classical question on perianeurysm rupture. 35 years old patient is having diaphoresis. Diaphoresis, high BP, palpitation. So the answer is very simple, pheochromocytoma. So this is again a repeat old question. This is a repeat question. So repeat question. 47th question is a repeat question. No doubt in that. Yes, Aziz, you are true. They are doing so much. National board examiners, some fellow is sitting there with so much of intention to fail all of you. So brain tumor in female patient with a headache, dural tail sign image, tumor arising from dura. So this is actually a case of meningioma, but I could not collect the complete choices. So it's a meningioma case because meningioma will have dural tail calcifications, tumor arising from durameter. It will have calcium holes known as samoma bodies. So I could not get the complete question, but the answer here, if I can go, is tumor has calcium holes. That can be the answer for this question. So it's a question on meningioma. So meningioma can be asked in the exam. Meningioma will be asked in exam in detail. So any doubts you have, these are the 48 questions. And you can see, I can tell among the 48 surgery questions which we have now seen, among this, definitely whoever taking conventional FMG classes would have taken only 15 MCQs. 15 MCQs only are direct repeats. Direct repeat means only 15 questions are direct repeat. Around 15 questions MCQs are near related concepts. So totally 18 questions in surgery are new, are controversial, are another level MCQ. Okay, are not controversial. None of them are controversial. Are new or NEET SS level questions. Please remember NEET SS level and INI set question, not even for NEET PG. I can tell around 18 questions I can pick up and give to the national boards to give grace mark. 15 questions are not to be asked for MBBS standard. 18 questions are not MBBS standard. They are MS standard. Okay, not should have been asked. So only out of this 48, I can tell maximum you can get 30 questions only. Even if you have read thoroughly, even a surgery PG is going to come and write this exam, they can only make 30 questions. Correct. Yes, options they made. I'm telling you this that's what I'm telling. 15 MCQs are nearly related concepts, but with the tricky options. Very tricky options, confusing you, making you go wrong in this 15. So therefore, I don't know about medicine and OG, what happened in paper to other papers, but surgery paper is so much of complicated questions. So any doubts you have, you can post now. I can clarify your doubts. Dr. Teja Kumar in front of Jungle NMCNB advocate said, sir, we have oral cancer or from federal government, please. Okay, maybe there may be something that Rajamahendran, because I don't know why this type of tough questions. Let us see if NEET PG is also going to come like this tough now. We cannot say so, but they are increasing the standard of question. That's what I can say. They are increasing the standard. They are increasing more tougher questions. Maybe they are moving towards more of next level questions, next pattern questions. Any doubts? If you have, please tell me. Okay, any doubts? So this is about the 48 questions in surgery. Sami Radhar has asked, it was like a cauliflower mass from the anal verge. No, please don't forget, there is squamous cell cancer of anal canal. We don't do wide local excision. Squamous cell cancer of anal canal, that in anus, this is a 4 centimeter anal canal. In this, there are 2 epithelium. This is columnar epithelium. This is squamous epithelium. This is squamous epithelium, and this is columnar epithelium. So columnar epithelium, we get an adeno cancer. So adeno cancers, no doubt, we have to only go for APR, abdominoperineal resection, because their nature is somewhat higher. Whereas squamous cell cancers will protrude like that only. They will grow and protrude like a cauliflower mass only. Even if they protrude, radiotherapy will cure them, will melt them like an ice, will cure them. No need of any surgery. If you do, you should not do any surgery. In fact, everything will be all right. Okay. Any other doubts you have? So those who are NEET PG aspirants, you can go and take care of your preparation, because these questions will be this type only. So you can keep preparing. Surgery questions, I think most of these type of questions will come for you. Okay. Thank you, Rajkumar. Thank you, Aziz. So I think thank you all. Yes, we definitely this type of questions will be expected in NEET PG also. Don't expect an easy paper after so much of postponements in NEET PG. Definitely the paper will be tough, and go prepared accordingly. Read the concepts and go for your exam. No, I'm not going to assist Megmod. I have already told I'm not going to teach any more separately for FMG. Actually, this question paper, if I have taken same class what I took for NEET PG, I would have definitely covered 35 questions. Many of my students, NEET PG students sitting here, they would have known many topics I have covered in NEET PG classes. But FMG, I'm sure I have taken in some places like Chennai and Delhi and all. I didn't take this much depth because we never expected the paper will be like this. Especially I had a rapid revision session in Delhi last month for 2 days. In that class, I was taking in depth combined with the NEET PG aspirants. Many FMG aspirants left the class because they felt it is too much for them. But actually, those students who attended that class on the last 2 days, they would have attended at least some 7 or 8 questions. So definitely this type of FMG classes we are not going to take in future. The classes for FMG will be a regular NEET PG like class only. There is no separate class for NEET PG or FMG hereafter. So prepare like NEET PG aspirant, because when next comes, you are going to compete with the Indian medical graduates. And definitely you are going to get much better score because you are preparing for so much of time, so many years. So all the best. Okay. So NEET PG 2023, we have NEET PG 2023. There is no expected. I'm telling you, all the points, 450 pages of notes I have in my Telegram channel. So 400 pages of notes. Definitely you have to focus and read on all the concepts. So you can see this, you can see when FMG exam, when we are asking, we always used to tell in FMG exam what are important topics means. We used to always tell, not only me, all the faculties will tell FMG exam, there will be trauma, so many questions will come. See, sutures, no many questions will come. None of the question came from suture. No, not even a single question. Not even a single question came from suture. We used to tell trauma, sutures, breast. Luckily, some questions came from breast, that are more controversial. And we used to tell GIT, and some topics like urology. So these are the usual topics for FMG exam. But you see in this paper, they have gone out of so much of syllabus. So many questions were come from various areas. So therefore, I feel you should give high importance to the concepts rather than reading MCQs in the last minute of exam. No need of wasting time on so many MCQ banks. I'm telling you again and again, this is what I will tell you. MCQ banks will never help you for your exam. You should only read concepts. Concepts only can help you. You can create, when you know one concept, for example, you know a concept of congenital hypertrophic pyloric stenosis, you can answer, you can yourself make 100 questions from that question. So once you are ready with the concept, you can answer any question. When you start reading like MCQs, you will only focus on MCQs. You will not be able to face the ball bowled by the examiners during the exam time. So I request you all, please read the concepts. That is the only change you should do now for the future exams. So all the faculties also should change themselves. Instead of going for MCQ-oriented teaching, should teach the concepts. You can see what is, so you're asking, sir, what is this concept you're telling? I'm telling you, this is what I'm telling the concept. What is concept? In a management of primary hyperparathyroidism, if I am teaching like a one-liner word, what I will tell? Primary hyperparathyroidism. Investigation of choices, I should do system scan and ultrasound. And I will do a surgery known as minimally invasive parathyroidectomy. That's all I would have finished. See, but I'm now telling you, when will I do minimally invasive parathyroidectomy? When will I do bilateral cervical exploration? Like that, you should change yourself, your preparation. When you read a concept, read it to the depth. Read it to the depth, understand that concept. Once you understand this concept, you need not revise at all. Once you understood the concept, you can easily answer. There are only some 200, 300 concepts in entire surgery or in entire medicine. 300 diseases, just 300 diseases you are going to read in medicine and 300 diseases in surgery. So you prepare like that in future, definitely you will be the highest scorer. No, don't worry about it. Yes, definitely. As I will tell you, the surgery they have done, worst paper is done in surgery. Among the 48 questions, I'll tell only this. Don't know about medicine. I think medicine, Dr. Rahul Raju sir is going to discuss soon. And OBG also, some faculty will be discussing soon. So let us see how the questions are going to be. Thank you all, friends. So don't give up. So keep preparing. Hope the examiners will have some courtesy for you and give some grace marks and clear most of the students this batch. Last year it was only 10% pass percentage. We are all very much worried seeing the question paper, how much it is going to be this year. Okay. So thank you all, friends. Thank you all. See you soon in another session. Thank you. So hereafter my sessions will be for a national board syllabus. That's all. So there won't be any separate FMG preparation. Always you should join along with the NEET PG aspirants, prepare along with the NEET PG aspirants. Thank you. So, thank you.